here are my objectives. First, I'm going to give a quick crash course of our current antifungal agents, and then we'll discuss clinically relevant Candida infections, and I'll spend a little bit of time on Candida infections. I think those are the most common that we see. And then I'll talk about other clinically relevant both yeast and molds that you need to know about, and then we'll review just some of the endemic fungi within the United States, because those will definitely be on the boards. So I call this Antifungals 101. This is how I think of antifungals, and this is kind of how I categorize them. So the first class I think about and that I like are the triazoles. And these are things like fluconazole, voriconazole, posaconazole, itraconazole. And these kind of have some variable coverage. And so first of all, they have some variable Candida coverage, and their Candida coverage doesn't really increase as their generation increase. And so their Candida coverage is just variable, and you have to know which Candida you're growing to know the coverage. What the trials, though, are important is that as you increase in generation, and I'll go through the generations here in a second, you actually increase in your mold coverage. The next group I think of as my broad spectrum molds and Candida coverage. So these are the polyenes, and this includes things like amphotericin and nystatin. And these really are broad spectrum. And so these are your broad spectrum antifungal coverage. Unfortunately, there are some Candida and there are some molds that are resistant. And so knowing those and knowing that you should probably always get sensitivities if you have a clinical infection is important for Candidas particularly. Echinocandins, so these are things like mycofungin and caspofungin. These are broad spectrums for Candida or yeast infections only. And so these have no mold coverage, but these are really good for Candida. And the majority of our Candida species is sensitive to it outside of really Candida auris. And Candida auris is variable. Flucytosine, the only thing you really need to know about it is it's a good adjunctive therapy. I misspelled adjunctive, so forgive me for that. And then griseofulvin, we're not really going to talk about, but you can use it for dermatophytes. So this is the table I made, and this is the way I think about pros and cons of each antifungal. So for echinocandins, so mycofungin or caspofungin, they're really great broad anticandidal drugs. And so if you're worried you have candemia, and echinocandin is the drug to go. They're relatively safe, and there's really no dose adjustment needed. What's bad about them, though, is they really get poor, honestly, tissue penetration, but they have no CNS penetration. They do not get into the eye, and they do not get into the urinary tract. So you cannot treat a meningitis with an echinocandin, and that's an important point. Our amphotericin and nystatins, these are broad spectrum coverage. They've got some CNS, they have some CNS penetration, but they do have a high risk of nephrotoxicity, and they have a lot of other complications. And these are broad spectrum. And so like antibiotics, and we don't want to treat people with broad spectrum antibiotics, we don't want to treat people with broad spectrum antifungals either unless we need to. The triazoles are a growing class and continuing to grow. The pros is they all have really good tissue penetration, including CNS penetration. And so fluconazole, voriconazole, and even itraconazole all have CNS penetration. And then the cons is that you have to know your resistance. There are increasing resistance, particularly within the Candida species. And depending on what generation you are will depend on mold sensitivities. And they also inhibit the CYP P450 enzymes, and so they interact with a lot of drugs, and so understanding your drug interactions is very important. And then flucytosine, pros, it's a good adjunctive therapy, but the cons, it should never be used as monotherapy because it has a really high emergence of resistance and kind of lots of. And like I said, I was going to mention the triazoles a little bit more because I think we use the triazoles probably, and the echinocandins are the two we use most commonly, but the triazoles are really different as we increase in generation. And so fluconazole, we're not going to talk about ketoconazole, but fluconazole is kind of the lower of the generations. Things about it, it's really good CNS penetration. It's got really good vitreous penetration and really good urinary penetration. And so these are good for like things like Candida meningitis, Candida, a UTI secondary to Candida species, or even an abscess secondary to Candida species. Fluconazole would be your agent of choice. The other thing about fluconazole that really is good is that it's 90% bioavailable when you take orally, which means it's a good oral agent, and you don't need to send them home with a PICC line to improve your concentration. Itraconazole is the next one up. This one's it's really key is for the endemic fungi, and that's really where we use it for. The problem with itraconazole is has really terrible variability in GI absorption. And it depends on if you take a capsule or if you take a solution of whether you need to take it with food or drink. With the capsule, it likes high acid, so people that are on PPIs or H2 blocker, it actually doesn't absorb as well. We recommend people taking it with things like a Coke or some orange juice to really help with the absorption of it. And then the solution does not require as much acidity, and you want to take it on an empty stomach. For voriconazole, it's excellent CNS and vitreous penetration, but it actually is one of the only triazoles that really has no urinary secretions, and so it's not a good drug for like pyelonephritis and things like that. Voriconazole does need to be, if it's an IV form, because of one of the adjunctives actually within the IV formulation, it needs to be dose adjusted by the kidney, but if you're giving the PO formulation, you don't need to dose adjust by the kidneys. And patients actually have variability in their metabolizer status and variability of their levels. And so voriconazole, you have to check levels pretty regularly. The next kind of class is the posaconazole, and this is the next generation. It has better mold coverage. While it's not FDA for Candida coverage, in vitro and clinically, there's lots of evidence to show that it does have Candida coverage, and so we use it for Candida coverage. You can use it for Candida coverage. And then itraconazole also can be used for Candida. Both posaconazole and itraconazole have higher grade mold coverage. So I'm here from my first case, and I have found that these can be a little bit more difficult for people speaking up while they are talking or through this venue. And so I'm going to give you a case, and please kind of chime in, or I'll just move on. So I have a 35-year-old, previously healthy male who injects drugs, who basically presents with acute respiratory distress. Admitted to the ICU, intubated, and required multiple pressors. Chest x-ray you can see on your right-hand corner. 12 hours later, his blood culture comes back positive for MRSA. He's initiated on vancomycin. 2 days later, he has some mucus plugging, let's say, and he got a BAL, which the fungal culture on the BAL is now growing Candida albicans. So what do you want to do? What do you think this is, and what would be your ideal therapy? Any thoughts? Okay. So this is Candida just growing from a bronch culture, and we'll go through this a little bit more, but I wanted to stress here that this chest x-ray looks like septic emboli, and this person has known MRSA bacteremia. And so he's not a person, and he's not been in the ICU for a prolonged period of time, and he's previously healthy other than injecting drugs. And so therefore, the likelihood of him having a Candida albicans pneumonia is very, 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 very low. And so this is likely a colonization that's grown on the BAL and is unlikely to need treated. And so let's talk about Candida infections. And there's a variety of presentations. You can have non-invasive versus invasive. The non-invasive are fungal. You can have mucositis or esophagitis. You can also have bone and joint, which would be more invasive, CNS disease or candemia. Pneumonia secondary to Candida species are very rare. And really we only see it in immunocompromised individuals. The majority of the time when we culture it, whether it's from a sputum or from a BAL, it just reflects oral contamination and colonization. And if you think about it, the longer you're on antibiotics, the more likely you are to have Candida colonization as well as Candidal infection. So knowing that it's very rare and that we shouldn't treat it unless really it's clinically relevant. So let's go through some kind of focal ones first, or focal infections first before we do invasive. This is oropharyngeal candidiasis. You'll see this more than once in your career. So you can see here are kind of these white plaques that you see with oropharyngeal candidiasis. There's also a Candida denture stomatitis. And so what you can see here kind of where his dentures were, these very erythematous kind of lesions kind of throughout here on the base of the palate and kind of on the gum line. And so those are both very typical presentations of some sort of oropharyngeal candidiasis. Treatment, and I copied these and pasted these right from the IDSA guidelines, and they basically go in for those that have mild disease and those that have moderate disease. And I wanted to point out that if they have mild disease, actually topical antifungals are really the way to go, whether it's clotrimazole or miconazole or nystatin, but something topical is really the best way to go for mild disease. If you're worried that they have moderate to severe, you can give a dose of oral fluconazole for 7 to 10 days. The next one I wanted to talk about, just moving down, is Candida esophagitis. And so it's actually the most common cause of odynophagia in immunocompromised patients. And so if you have a patient with immunocompromised, it's particularly those with cell-mediated immunodeficiency and those with no neutrophils, you need to really think about Candida esophagitis. Remember that diseases, not just HIV, but diseases like really uncontrolled diabetes can also present with Candida esophagitis, as well as solid organ transplants and people on active chemotherapy. However, if there is no known immunocompromise, you always need to get an HIV test in these patients. It's really important to always get an HIV test. Treatment of choice is actually fluconazole. You can do 21 days of fluconazole. The echinocandins, though, also should be working for Candida esophagitis. Vulvocandidiasis, I didn't want to show any pictures of it, but treatment of it, again, is topical, except if it's severe, and if it's severe, then you can use a dose of fluconazole. So let's talk about invasive Candida disease, because I think this is really important. And until very recently, I didn't realize how common it was really in the healthcare system. And I've seen this anywhere from 3 to 5 in different papers and in different studies, but it's actually one of the top pathogens causing healthcare-associated bloodstream infections. And 50% of these invasive Candida diseases is in the ICU. And so patients in the ICU that are having fevers without really a good cause, you have to think of Candidal disease. Risk factors include if we've immunocompromised them some way. And so are they neutropenic? Do they have a malignancy? Are they on any sort of immunosuppressive agents for their cancer or for their solid organ transplant? And then did we medicalize them? And so are they on prolonged antimicrobial antibiotics? Have they had multiple lines? Are they on dialysis, both peritoneal dialysis as well as intermittent hemodialysis? Are they have any like major abdominal surgeries, things like necrotic pancreatitis, things that upset the stomach and kind of the gut, and then long-term ICU stays. So those are all risk factors, and those are all patients you need to think about if you have a patient that's not getting better on broad-spectrum antibiotics. And the other thing that's really important is that early intervention is really associated with better outcomes. And so if you suspect Candida, getting them started on an anti-Candidal drug is really important, and that'll improve the outcome of your patients that have true Candidal disease. There are over 15 distinct species. The majority that we see are listed here outside of the ORAS. So Candida albicans, Candida glabrata, Candida tropicalis, Candida parapsilosis, and Candida krusei. Glabrata and krusei are two that you have to worry about azole resistance. So glabrata is typically dose dependent to an azole, and krusei is resistant to fluconazole. And so you need to remember those are two that you should recognize if you see their names, and remember that they're a little different. I put Candida auris on here. I debated on whether or not to put it on here, but Candida auris is now actually seen in Ohio, and we have cases in Ohio. And so we will probably start to see more Candida auris as time goes on. And so just remember that Candida auris does have significant resistance, depending on where the species was from, depends on its resistant patterns. And so those outside the United States tend to be more resistant to the Candida auris that we've seen within the United States. So knowing if you grow Candida auris, knowing your patient's travel history is very important. Diagnosis, so blood culture or cultures really are the gold standard. And I wanted to stress here that in this day and age, doing a fungal blood culture is not necessary because the bacterial blood cultures actually Candida, or the typical blood cultures actually grow Candida as well as the fungal blood cultures. And so if you're ordering a fungal blood culture for Candida, you do not need to because it should grow on a typical blood culture. I do have to say, so if you're candemic, blood cultures are pretty good. But if you're just looking for invasive Candidal disease, it's not necessarily good because those patients may not be consistently candemic. They may actually have intermittent candemia, and so you may actually miss it with a culture. And we've been trying, and there are lots of other ways that people have been working on to try to diagnose Candida and invasive Candida, and there's lots of work being done on that. In this institution, we use a lot of beta-D-glucan, which is a cell wall component of Candida and other fungi. The problem is beta-D-glucan is not very sensitive and it's not very specific. And so you can see here, its sensitivity has been anywhere from 75 to 80%, and the specificity, they listed 80%. I got these from the IDSA guidelines. There are other studies that have other variability. So there's just not a good sensitive and specific test. And it has a lot of false positives. So certain gram-negative bacteremias can cause them to be positive. Antibiotics, particularly the penicillin antibiotics, can cause a false positive because if you think about it, they come from penicillium, which is also a fungus that also has the cell wall constituent. People on hemodialysis, the tubes can have some of these, just pieces of these, the pieces of the beta-D-glucan that are not active fungus, but just kind of that protein. The fluconazole colonization, fungal colonization, we've received albumin or megalobulin, any sort of surgical cause, and then mucositis or any disruption in the GI membrane, all can cause false positives. So there's a lot of things that can cause a false positive in a beta-D-glucan. There are also some PCR technologies coming out. I'm not going to go into those, but there are coming out. And I didn't add it on here, but there's also a test called the T2, which basically looks at the magnetic kind of, it's like an MRI technology looking at the different organisms. So there's lots of new research coming out in this area. So hopefully we'll have better information about this in the next couple of weeks. There is, and I wanted to point out, there is this beautiful guideline that actually is not that old. It's only 4 years old, that really goes through candidiasis and the treatment and practice of candidiasis in patients. Going through, and this is a long list, but kind of looking at individuals. And so neutropenia with candemia, we're going to treat with echinocandin. If they have chronic disseminated, you think about amphotericin or echinocandin followed by fluconazole. Non-neutropenic or in the ICU. In the ICU, you think about echinocandins. If your ICU rate of invasive candidiasis is greater than 5%, you want to do fluconazole prophylaxis. That is, as far as I'm aware, our rate is not that high at UC, and so we are not doing fluconazole prophylaxis. But depending on where you go, you probably want to know that rate to know if you need to prophylax. CNS disease, remember I said echinocandins do not get into the CNS, so all CNS disease, you need to do amphotericin plus or minus flucytazine and then fluconazole for step down. Endocarditis, they recommend amphotericin or echinocandin with fluconazole step down. Osteoarticular, fluconazole. Endophthalmitis is azole plus or minus surgery. If you're asymptomatic and you have candiuria, you don't need to treat unless the patient's neutropenic or if there's an invasive urological procedure. If there are any med-peds people on here, when you're in the NICU, babies that are premature and they have asymptomatic candiuria, those are also needing to treat. And then if you have cystitis or pyelonephritis, you think about fluconazole, and then a fungal wall, you think about surgery. So going back to what I said about the antibiotics in that first table I showed you on drugs or antimicrobials, echinocandins can be used except for in places that we concentrate tissue, like the CSF, and with a severe disease, we use amphotericin first. If it's not severe disease, but we want to go to the tissue, we're going to use an azole, particularly fluconazole. So my conclusions for Candida, if you have an ICU patient and you're suspicious, you should consider treatment. If you have a positive respiratory culture, you should ask yourself, is it truly infectious? Because it rarely is. If it's a disseminated, you want to get an eye exam and an echo. Fungal blood cultures for Candida are no better than typical blood cultures, and the beta-D-glucan is neither specific or sensitive. Treatment, if it's candemia process, you want echinocandins. If it's in the CSF, you want amphotericin, and that includes the eye. If you want into the tissue, you want fluconazole, and if it's in the urine or the respiratory and it's asymptomatic, you do not want to treat. Cool. I'm going to move on, but before I move on, are there any questions about Candida? I'm going to move on. So here's our next case is a 55-year-old gentleman with history of AML who presents with maxillary sinus pain and proptosis of the right eye and fever. Was found to have bruising around that eye and the nostril, and then had actually a scar in the nostril. ANC's 100. Which of the following is your diagnosis? Would anybody like to make a guess? Okay, so the answer is, I guess you all have discussed or thought about in your head, this is aspergillus. Does anybody know what the treatment is? So surgical debridement would be your treatment in this case. So aspergillus is actually a mold. So we're moving from our Candida, which is a yeast, to our molds, and it's ubiquitous. We all get exposed to aspergillus at various times of the day. And it can become infectious when it's acquired via inhalation. You actually inhale the spores, and it can present in various ways. You can have just colonization, so we can bronch somebody and they get bronchs because we wanted to look at a nodule for malignancy, and they have malignancy, but it grows in a bronch. You can be more of an allergic component, so allergic bronchopulmonary aspergillosis, or ABPA. You can have an aspergilloma, you can have invasive aspergillosis, or rhinosinusitis. And so I wanted to talk about ABPA first. And this actually isn't true infectious. This is more of a hypersensitivity to colonization. And we see this in patients that you think about don't necessarily clear their colonization as well. And so people with things like bronchiectasis or cystic fibrosis and things like asthma. And they basically get these like pulmonary asthma symptoms. And so for patients with cystic fibrosis, they may or may not be clearing, or they may have decrease in their pulmonary function tests and just not feeling their base pulmonary status. I've seen kids that with cystic fibrosis that were playing sports like soccer, and they went from being able to run a whole game to where they could only walk into the hospital. And so it can be pretty significant. They get these like fleeting pulmonary infiltrates. You can see peripheral eosinophilia, and then the diagnostic is really done based on this aspergillus precipitating antibodies or elevated IgE. Treatment for ABPA is the mainstay is steroids. The mainstay of therapy is steroids. You can also use azoles, and you also need to use an azole as well, particularly voriconazole. You can use voriconazole above. Aspergilloma, you can see here, is this colonization of a pre-existing pulmonary cavity. Patients can be completely asymptomatic, or they can have hemoptysis, dyspnea, and weight loss. So it just depends on kind of how that patient presents. You can see here, it has a little bit of a round ball within a cavitary lesion, and that would be what an aspergilloma really looks like on imaging. If they're asymptomatic, you don't need to treat them. If they're symptomatic, anti-fungals, you can try anti-fungals if they're not a surgical candidate, but really surgery is the mainstay of therapy, because if you look at this ball, it's going to be really difficult to penetrate that ball with any of our anti-fungals. Invasive or disseminated aspergillosis is the one that we're more scared about, and the one that I always worry about. And it's seen in people with profound prolonged neutropenia, or those on immunosuppression. Those that are critically ill with steroid exposure. And there's actually becoming more and more literature coming out that those that are critically ill that have a post-viral infection. And so actually with the SARS-CoV-2 outbreak, they have been seeing a higher incidence of aspergillus infection in these patients post-infection. And it's actually been described prior to this outbreak in people with influenza. And so it's something that you need to keep in the back of your brain. Symptoms include fever, cough, chest pain, and hemoptysis. And what's really kind of scary and why they get such bad hemoptysis is these are actually invade the pulmonary blood vessels, and they can cause distal infarcts and lung. And that's really the invasive, that's when you decide it's invasive, is when a biopsy really shows this invasive invasion into the pulmonary blood vessels. It can go other places, and so it can become systemic. It can go to the brain and cause brain abscesses. It also causes heart, GI, and skin disease. Here is the image finding. And so what happens is you get this targeted lesion of necrotic tissue that's surrounded by a ring of hemorrhage. And you can see it kind of in this area. The word that you'll see, and the word that's this is typically described by, is the halo sign. And so sometimes in the radiology report, you'll see this described as the halo sign. And then you also can get on a chest x-ray these like wedge-shaped densities that would resemble an infarct that you would see with PE. This is by far the most scary for me, and we'll talk about another fungus that causes this in a little bit, but rhinosinusitis disease, because these people can get sick very fast. And so this is you have to worry about this in people that have hematological malignancies, skin cell transplants, they're on chemotherapy, solid organ transplant, advanced HIV, diabetes, or steroids, both systemic and intranasal. And what you would see is it would be somebody that would be presenting with pain and kind of sinus pain, possibly proptosis of the eyes. And you get a CT and you'll actually see this this like osteonecrosis area, or this osteonecrosis area that you can see what these arrows are pointing to. And it's very serious, and getting ENT to see these people as soon as possible is really important. And so if you have a person that has a poor immune system that's presenting with a sinusitis, that's not, particularly if it's not getting better with antibiotics, this needs to be in the back of your mind. Diagnosis for aspergillus, particularly invasive aspergillus, is always tissue biopsy. Blood cultures are rarely positive, and for molds would be a reason that you need to get a fungal culture. And so mold is the reason to get an actual fungal culture, not Candida. And so you can see here, this tissue biopsy, you can see these kind of hyphen organisms that have hyphens at 45-degree angle. And they're septated, and so that's really what you think about when you see aspergillus. And you can see here, this is a blood vessel, and this arrow here kind of shows an aspergillus right here. You can see the 45-degree angle actually having that angioinvasion, and so that's really what makes us confident that this is aspergillus. Galactomannan is a part of the cell wall of aspergillus, and it's particular to aspergillus, and so while it can be specific for aspergillus, it's not as sensitive. The best data done in bone marrow transplants and actually trending bone marrow transplant patients, because if their galactomannan goes up, that's suggestive of that they could be developing an invasive disease. And so that's where that literature comes. We use it sometimes as a marker of diagnosis because it is hard to diagnose without biopsy. And then beta-D-glucan is also in the cell wall of these and can be elevated in aspergillus. Treatment, it can either be voriconazole is the drug treatment of choice. So if you have pulmonary disease or you have something like that, you can use voriconazole. If you have rhinosinusitis, you want surgical resection, so you want to get ENT involved early. Next one is mucormycosis. So this is also a mold, and this causes a rapidly fatal rhinocerebral infection, and that's what it's most commonly known for. These patients these are immunocompromised patients. It was well described in hemolytic malignancies, but it's also now been described in solid organ transplants, those with active chemotherapy, and those with uncontrolled diabetes, particularly those that have recurrent ketoacidosis, because the ketoacidosis actually inhibits some of the cell function that allow for clearance. People with iron overload states, so those that are on kind of continual blood transfusions for whether it's their sickle cell disease or they have hemochromatosis, but those are at higher risk. These patients have, on exam, a pathognomonic black eschar of the nose or palate. And so if you have a patient that has a severe immunodeficiency for some reason, that's having some facial pain, this needs to be in your thought process, and you need to do a good nose and palate exam. Other kind of pulmonary diseases is it causes thrombosis or infarctions, and then it can cause skin and CNS disease. Skin disease you can see particularly in burns patients, and CNS disease, people who inject drugs. If it gets into some of their drugs they inject, it can actually go to the brain, and that's where it's been described, although it also can be seen as a directly from their sinuses in those that have rhinocerebral infections and those that are immunocompromised. To diagnose this, the diagnosis of choice is really biopsy and tissue. It's a non-septate, so you see it here on your right. It's a broad, irregular, and ribbon-like aseptate hyphae, and it's supposed to have these 90-degree right-angle septae. Or I'm sorry, not septae, right-angle hyphae. They're aseptate, right-angle hyphae. And what's interesting is since they're aseptate, they actually die quickly whenever they're brought to the microlab, because we grind them and we're a little rough sometimes with our tissue samples in the microlab. And so they don't always grow. And so if you're worried about mucor, it's always good to call the microlab and let them know, because they're a little bit gentler with the samples sometimes when they're looking for mucor. The other really important thing is that these do not have beta-D-glucan or galactomannan in their cell wall, so they will not be positive. So do not say, oh, my beta-D-glucan is negative, I don't think this is mucor, because that is not true and you will miss mucor. The treatment of choice. So if you have a person that comes in with facial pain, and especially if they have a black eschar either on their palate or their nose, you need to call ENT. This is an ENT emergency, and they need surgery. So surgery, especially for rhinocerebral disease, is really treatment of choice. Amphotericin has been our old use drug that we used to use for all of these. Nowadays, we do have newer azoles, so posaconazole and isavuconazole both have some activity against mucor, we just don't use them as frequently, but they're becoming more and more used for mucor. And there are newer azoles coming out for mucor. Cool. Any questions on molds? Or those two molds, I should say. Cool. So let's move on. I have a 65-year-old with history of hypertension presenting with altered mental status, fell off a ladder 3 months before, and had some altered mental status though during his hospitalization, and had an LP performed at that time, which showed a white blood cell count of 25, a protein of AV. He believed it was viral. Repeat imaging, so came in with this altered mental status. Repeat imaging showed some ventriculomegaly, and that's his lumbar puncture that you guys can see. Do you guys want anything else on the workup? What's your all's thoughts on the differential? So this is Cryptococcus. And Cryptococcus, and I actually presented this case like this because I saw this patient. I saw this patient my first year of residency. And so it's important to think about Cryptococcus even in older people. And so Cryptococcus neoformis and Cryptococcus gattii are the two clinically relevant Cryptococcus that we see in the United States. Cryptococcus neoformans is the most common. Cryptococcus gattii was actually associated with an outbreak in Northern California, Washington, Oregon area. And so we more see it in the Northwest. You get infected from inhalation, and it causes this disseminated pulmonary disease. It particularly causes a disseminated pulmonary disease in patients that have a cell-mediated immunodeficiency. And so when you're thinking about diseases, or about people that are at risk for Cryptococcus, think about people that don't have good cell-mediated immunity. So people with AIDS, solid organ transplants, a lot of our immunosuppressions are cell-mediated. Steroid dependence and people that are on chronic steroid treatment, those with type 2 diabetes, liver dysfunction, and kidney disease. And there is a subset of older gentlemen that typically have liver disease that are actually at higher risk of cryptococcal infection, and it's been well described. So if you have a gentleman that's 65 that, let's say, drinks 2 or 3 drinks a day, doesn't have to have full-fledged alcoholism, but maybe has a little bit of fatty liver, you need to think about Cryptococcus if they're coming in with headache, altered mental status, and signs of ventriculomegaly on your exam. This disease, you can get CNS disease, skin disease, prostate disease, eyes, and urinary tract. CNS disease is really where I wanted to focus. You can get headaches, altered mental status, fever. When you think about it, it causes a pretty significant increase in intracranial pressure. So you're going to get these intracranial pressure signs like diplopia, decrease in visual acuity, and then you'll get some extraocular nerve palsies kind of related to that increase in pressure. The diagnosis is a cryptococcal antigen from both, you can get from both the serum and the CSF. I will say that Indian ink stains are one of those things that you hear about all the time, and you learn about them in med school. We don't do them clinically anymore. The cryptococcal antigen is the better test. There is also a meningitis profile that looks at PCR. It looks like has a group of PCRs through the CSF. Cryptococcal is on that. That PCR is not very sensitive, and so if you are suspicious for cryptococcal meningitis, you need to send a cryptococcal antigen. In HIV patients, if you can't get an LP, the serum is pretty sensitive, and so if you have a negative serum, it's less likely. Patients without HIV, this is not as true. And then a lumbar puncture, when you do a lumbar puncture, you'll have a really high opening pressure. You'll see a lymphocytic pleocytosis and a pretty high protein. So if you see those things, you need to really think about Cryptococcus. Treatment depends on your HIV status and your immune status. If they have AIDS, you want amphotericin plus flucytosine for 2 weeks, and then 8 weeks of fluconazole at high dose, and then 1 year at least of fluconazole. For transplant patients, similar, but you may be able to get by with 6 to 12 months of fluconazole. For non-HIV or transplant patients, you can do amphotericin plus flucytosine, and they recommend for 4 weeks, and then fluconazole for 8 weeks, and then to 6 months to 1 year. The 4 weeks is really expert opinion because there were studies before the azoles that showed the 4 weeks was better. To be honest, though, there's a lot of debate within the ID community of whether they could really get by with 2 weeks for non-HIV patients. And so probably more to come on that as the guidelines change. Depending on the underlying etiology or your underlying immunodeficiency, particularly with transplant patients, you may need to consider lifelong suppression after treatment is done because their immune system will never be normal. Whereas a patient with AIDS, if you get them on highly antiviral therapy, their immune system should recover. The last is that you always need to think about intracranial pressure management for Cryptococcus because it really does cause pretty significant increase in intracranial pressure. And so these patients are going to need frequent lumbar punctures, and many of these patients go on to need VP shunts placed because of that intracranial pressure. Where do I remember all this? There's a beautiful IDSA guideline. It's actually pretty old now. I've heard rumors that they're putting a new one out, but I've not seen any details on that. So hopefully it'll come out soon because this is coming out to 10 years old at this point. Next case, 40-year-old admitted with, and this one came straight from MICSAP, so I tried to shorten it. So 40-year-old came straight with hypoxia, headache, dry cough, and flirt chest pain, has some tender nodules on the soft tissue, which she calls her lumps on her legs. Was in Arizona last month and was at an outdoor art convention and has a history of Crohn's disease. She's on infliximab, which is a TNF-alpha inhibitor. She hear coarse crackles, rhonchi, has a positive mycoplasma IgM, a chest x-ray, which is some bilateral disease and some lymphadenopathy. So what would be your most likely diagnosis? So giving you a little time to think about it, you know we're at a fungus talk, so mycoplasma is probably not the right answer. And so you're between the three, and based on the risk that they gave you, coccidioidosis is the answer. So coccidioidosis would be this patient. And so I really want to talk about the endemic fungi within the United States. Histoplasma is the most common endemic fungi within the United States. If you've not seen histo in this area, you have not been looking hard enough for it unless you've not been here very long, because we see histo all the time. It's in the Ohio and Mississippi River Valley. You can see here, this is where we are. And so what you do is we look at this map on the left, looks at the areas that have good soil concentrations, good growing conditions for histo. So areas that histo thrives, and you can see here, Cincinnati is right in that area that has good soil for histo thriving, and so does kind of right around the Ohio River Valley. And you can see here it correlates with the cases. And so up in Minnesota at the head of the Mississippi, you can see there's lots of cases and there's lots of areas that are optimal. And then going down in Illinois, Indiana, Ohio, kind of going all the way down. These patients usually actually are asymptomatic. And so the majority of patients that we don't see, and the majority of people infected are actually asymptomatic and don't really require therapy. People with cell-mediated immunodeficiencies and those on TNF-alpha inhibitors, though, are at high risk for dissemination. And so you need to think about those diseases when you see somebody on something like infliximab. There is patients that are, you can present with multiple different disease types, and I could do a whole lecture on histo, and I don't have time to do that. But you have pulmonary disease, you can get granulomatous mediastinitis, fibrosing mediastinitis, broncholithiasis, pulmonary nodules, disseminated disease, which can present with hepatomegaly, weight loss, and cytopenia. The diagnosis is biopsy with culture. You can get, you can see here on your right, this came from the Red Book, which is the pediatric infectious disease book. And you can see here neutrophil with little yeast kind of formed within it. Immunological testing, and the way I look at these, so we can do two things. We can either test the patient's immune system towards histo, and these are looking basically at the serologies, or you can test for the histoantigen itself. And the way I think about this is that if a person has a poor immune system, before they're going to be symptomatically diseased, they're going to have a lot of fungal burden or histo burden. And so therefore, the organism histoantigen is going to be more likely to be positive. And so looking at a histoantigen is reasonable in that patient. And a person with a high immune system or a high kind of functioning immune system, the bacterial burden of disease is going to be relatively low. Because the immune system is going to recognize it and cause a lot of inflammation and cause a lot of disease. And so it's going to be low. With a high immune, it's going to be low. And so therefore your immunological studies is probably the way you need to test for it. Histocomplex is a little bit more sensitive than a histoimmunodiffusion, which is why we recommend doing a histocomplement fixation. The next thing you get asked is the bacterial burden, where you expect that fungal burden. I'm sorry, not bacterial burden, that fungal burden. Patients with suspected high burden, let's say in the lung, if you've got a bronch specimen of that area with a high histoburden in the lung, it's going to be high. But in a person that's immunocompetent, if it's just in the lung, your histoburden is going to be low in the blood, it's going to be low in the urine. And so a histourine antigen and a histoserum antigen is probably not going to be very helpful because that's where you have a low burden of organism, whereas the lung, a histoantigen from a bronch is probably higher yield because that's where that high burden is. So just a way to think, the way I like to think about this testing. Treatment. Mild to moderate, no treatment, or you can consider itraconazole. Moderate to severe, you can use amphotericin followed by itraconazole. Acute progressive, amphotericin followed by itraconazole. And I just wanted to point out that itraconazole, remember the variability in GI absorption. So you have to get levels, and you have patients on this. You need to talk to them about whether they're going to take the capsule, whether they're going to take the solution, and what they need to eat and drink with each of those variabilities. Where do I remember this? Look, there's a lovely IDSA guideline for histoplasma. Blastomycosis, again, this is endemic in the Ohio, Mississippi River valleys, the Great Lakes, and the St. Lawrence River. This disease, you get infected by inhalation. It's typically pulmonary, and I want to say that this disease presents more like a typical pneumonia. And so you usually have an infiltrate on chest X-ray, not some non-specific bibasilar disease, which is what you can see with histo, or not lymphadenopathy, which is what you see with histo. This really looks like a bacterial pneumonia. You can also get other diseases in the skin. So you can get papules and nodules. The skin is the second most common cause of infection. Blasto tends to like the prostate and the joints more than and bones more than the other endemic fungi. And so that's a really kind of important part. The diagnosis is biopsy and culture again, and cultures are the best. We like broad-based buds. And you can see here, again, from the Red Book, you can see here these broad-based buds. For the prostate, you can get a urine fungal culture, and that should help you diagnose prostate blasto. There are also immunodiffusions and blastoantigens. These are not as sensitive, and they have more cross-reactivity, but they are available for use, and we do send them out frequently. Treatment, mild, immunocompetent, watchful, immunocompromised, moderate to severe, ampho followed by itraconazole. Again, there's an older but still accurate IDSA guideline for blasto. Coccidiosis is kind of our last one. There's intermedius and Posadii. It's endemic in the south of the U.S. and the rates actually are highest during the dry months or during soil disruption. So pulmonary, you usually see 1 to 3 weeks after exposure. A third of cases actually, sorry, this is really interesting. So in pulmonary cases, in places that are endemic, during times of during the dry season, up to a third of cases of community-acquired pneumonia are secondary to blastomycosis, which is really, or not blastomycosis, I'm sorry, cocci, which is really interesting to me. I did not realize that it was that frequent. Valley fever, you get subacute infections, respiratory symptoms, fever, and erythema nodosa associated with valley fever, much like our patient we talked about, and you get some arthralgias. Cocci really likes the brain and it really likes bones. And so we see more meningitis associated with cocci than we do with the other endemic fungi, and more osteomyelitis associated with cocci than we do with other endemic fungi, which is really kind of an interesting fact. This is risk factors for dissemination is AIDS, immunosuppression, particularly of cell-mediated immunity, and pregnancy. Diagnosis, cultures of diagnosis, I put warn the microlab because the cocci can be pretty infectious. And so if people in the microlab are growing it on a fungal culture, they don't want to open it up in the middle of the lab and release the spores everywhere and infect everybody in the microlab. So if you're suspicious for cocci, the microlab would appreciate the call. For testing, there are immunological testing that are probably more sensitive than the culture, particularly the EIA, which is better, more sensitive than the complement fixation or the immunodiffusion. These are all just various ways to check for antibodies. It's better for chronic, serologies are better for chronic meningitis because it doesn't actually grow well in our cultures, but it doesn't exclude disease. Treatment, if it's pulmonary and low risk, no therapy, but if you're high risk, itraconazole or fluconazole. Severe disseminated AMPO followed by itra or fluke, and actually cocci meningitis, fluconazole is first line. And then there's another, actually more recent IDSA guideline for cocci. So if anybody would like to read more about cocci, it's actually a pretty nice guideline. The last two I wanted to go over, these were the last two kind of within the mix app that I didn't actually think would be in there, but I wanted to just mention them. Sporal trichosis, remember this is found in soil and vegetation. So you see it in your test stem for boards, if they're gonna have a gardener or a landscaper that kind of curve his finger or her finger because it's acquired via inoculation. Usually a papula appears first and then it ulcerates and then it kind of goes up your lymph. You get like a lymphangitis type picture, and that's it, but it takes a long time. So it's days to weeks later. It's not a rapid spread. This is diagnosed by culture, and the treatment of choice is itraconazole. And then extracilium, this was something about in 2012, there was an outbreak with people that were getting epidurals as well as joint infections with methylprednisolone. There was actually a big outbreak, and this was big on the boards for a couple of years. I'm not sure if it's still continuing or not, but just so that you're aware, if your stem has somebody that gets an injection with methylprednisolone, think about exorhelium, and voriconazole and amphotericin would be your drug of choice. So my conclusion, fungi are fun. Candida is common, and particularly in ICU, so think about it. Adding a fungal blood culture, if you're worried about Candida, doesn't add any benefit and adds cost. So don't do fungal cultures, just candidal infections. The beta-D glucan is non-specific. So if you order it, don't say it's a definite diagnosis of Candida, but it can be helpful. If sinusitis in an immune-compromised individual, think about getting ENT involved and do a good ears, nose, and throat exam. Make sure you look at both the palate and the nose for any of that black eschar, and then know your location. Your boards will give you an obvious location for histo, blasto, and cocci. So know your endemic fungi locations. Cool. So if anybody has any questions, please let me know. You can email me, you can call me, you can page me, however you want to get a hold of me is fine. I'll be at the VA and UC the next couple of months, so you can also ask me if you see me in the hall. Any questions I can answer here? Okay.
I have a question, but this was great. Thank you, Hilary.
Yeah, no problem. Thanks, Scott.
We appreciate it. Thanks,
Bye.
everyone, for able to join. We'll see you later. Bye.